Hello, dear friends. In our series of applied neuroanatomy today, we are not going to discuss the anatomy. We are going to discuss the pathology. I know this is not the aim of this collection, but because of the very peculiar and special nature of the orbital pathology, so I decided to discuss the pathology of proptosis and orbit immediately after the orbital anatomy. Of course, a rapid review of the anatomy, and this is the axial view, CT, showing the superior orbital fissure, the anterior clinoid, and the optic canal, and the optic nerve, the globe, the recti, and the muscle cone. Surgical approaches, also a rapid review because it was already discussed in the lecture of the anatomy of the orbit. We have the lateral orbitotomy, accessing any lesion in the superior orbit, inferior orbit, or lateral compartments. The medial orbitotomy for lesions localized medial and anterior in the orbit, and the transcranial, the superior approach to the orbit, for lesions in the medial compartment but posterior, or reaching the orbital apex, or of course having intracranial extension. Also there is the endoscopic sinus, and it is a relatively recent subject. Lesions in the medial compartment or lateral compartment, you can take it via the endoscope from the ethmoid sinus, or you can reach even the lateral compartment without taking out the lateral orbital rim, without the lateral orbitotomy. You can reach the lateral compartment and even the orbital apex. So the lateral orbitotomy, it was discussed before. You do an incision along the covered by the eyeglasses, extending posteriorly for a distance of 2 centimeters to avoid the motor branch of the facial, and it is extending in the upper eyelid or in the eyebrow. I prefer in the eyebrow because if you're going to extend in the upper lid, you have to have an ophthalmologist with you. So this is the way I prefer to do the lateral orbitotomy, the eyebrow, and extending posteriorly along the line of the glasses for a distance of 2 centimeters, not more than this. And these are the steps, you know about it. And we said that this is the incision, and then we'll have the fascia temporalis fascia incised and temporalis muscle retracted posteriorly, and periosteum drilling or periorbita and peeling the periosteum posteriorly and peeling the periorbita from below. Then by the drill, by the osteotome or by the oscillating saw, we can cut the lateral orbital rim and we open the periorbita and to reach the lesion. And this is the left side, this is medial, this is lateral. A spatula is put between the periorbita and the orbital rim, and here the temporalis muscle is pushed posteriorly. And this is the extent of the bone we remove at the base with the zygomatic arch and superiorly medial to the frontozygomatic suture. This is the bone. To put it back again, it is very disfiguring if you take the lateral orbital rim. You have to put it back in this way and you close your incision. The transcranial, the most famous is the lateral subfrontal approach, having the advantage of not entering the frontal sinus, not reaching the olfaction, and not injuring the supratrochlear, supraorbital nerves, so less painful scar after surgery. Or you can do the pterional approach, or very, very rarely, if you have biorbital affection, you can do the bifrontal subfrontal approach. So this is the lateral subfrontal approach, or the subfrontal. This is the roof of the orbit, and this is from where you go superiorly. You can reach here any lesion, superior or medial, posterior, or reaching intracranial. The medial orbitotomy, as we said, it is for anterior medial lesions, lateral to the nose. You do your incision, and then you reach the ethmoid and reach the orbit. Another case, this is the right side, the nose is here, do the orbitotomy. And the endoscopic for such cases, you can do sublabial endoscopic reaching the maxillary sinus. Then the roof of the maxillary sinus is the floor of the orbit for the blowout fractures, so that you can repair the floor of the orbit, and you put the fat back again, and you put your artificial silastic or something to keep the fat in place. Or sometimes transnasal, and you go medial to the middle turbinate through the maxillary sinus, reaching the orbital apex of the other side. Or even you go on the same side and then you reach the ethmoid sinus, the sphenoid and the ethmoid. And the ethmoid sinus, what is lateral to the ethmoid is the orbital wall. The roof of the floor of the orbit is here, and the medial wall of the orbit is here. Always define a plane. When you're doing your surgery, you have to define preoperatively where is the tumor. Is it subperiosteal, having intracranial extension? Is outside the muscle cone or inside the muscle cone? And this is imaginary line showing the muscle cone. The space is outside, this is inside the muscle cone. Causes of proptosis. This is the subject of this talk, and I had to mention because not many places clarifying this very, very important subject, because the orbit is considered no man's land and there is overlap between different subspecialties. So causes of proptosis, we can classify it according to many things, but here is according to the site. So what is causing the eye to be pushed forwards? Is it an intraorbital lesion? Could be, like something called cavernous venous angioma, optic nerve meningioma, optic nerve glioma, orbital pseudotumor cellulitis, anything inside the orbit. Or it could be in the bony wall of the orbit. Many bony tumors, fibrous dysplasia, ossifying fibroma, osteoma, metastases, and mucoceles. Or it can be due to intracranial causes. Orbit has nothing, the bone has nothing, but we have cavernous sinus meningioma impeding the venous drainage from the ophthalmic veins. Cavernous sinus thrombosis, the same thing. Carotid cavernous fistula also engorging the ophthalmic veins, causing proptosis. And some entity called the meningioma on plaque, small meningioma with hyperostotic bone, causing the orbit to protrude, the globe to protrude forwards, causing proptosis. When we talk about the orbital pathology, it is very versatile, and it's so many pathologies are present in this region, as if you are have to name the name of the Egyptian kings and in a chronological way the years they governed. So it's a bit difficult, but we will make it very simple, as you will see. And the causes of proptosis, another classification is classification according to the age and cause. The age is very, very important in dealing with orbital pathology, as you will see, and the cause. So this is the only table you have to learn. This is a very important table. This could be the starting point of your subject when you are going to discuss proptosis. So you mention the origin of the lesion and the age of the patient. So we have origin congenital vascular, neural, mesenchymal from the muscles, hemopoietic from the blood components, and metastatic from different parts. If it is congenital in origin, in children you have the dermoid cysts and the teratoma. Of course, dermoid can present in adults also, but this is generally speaking. Vascular, in children we talk about the capillary hemangioma. It's not the cavernous hemangioma. Capillary hemangioma is mostly affecting the skin of a child with the upper lid and evident on his face, and it is diffuse and disappears by the age of 2 years. And the lymphangioma is a very special entity in children. Vascular, adults, cavernous hemangioma is a very common tumor. Hemangiopericytoma arising from the pericytes, which is the lining of the capillaries, and the orbital varices. Orbital varices, the proptosis changes with position, stooping forward or doing Valsalva maneuver, straining, you get protrusion of the eye. When you lie supine, it disappears. Very rare entity called varices. The neural in children is the optic nerve glioma and the plexiform neurofibroma, part of the neurofibromatosis involving the skin. And in adults, when you talk about neural, you talk about optic nerve meningioma, schwannoma usually of the nasociliary nerve of the ophthalmic division of the trigeminal, or neurofibroma. Mesenchymal, we are dealing with the muscles. We talk about rhabdomyosarcoma, which is the commonest malignant tumor in children from the muscle, and the acute myeloid leukemia. And mesenchymal in adults, we have fibrocystocytoma, and we'll discuss it. Hemopoietic, talk about histiocytosis X or xenophilic granuloma, and neuroblastoma, which is of hemopoietic origin, and adults lymphoma. Metastatic in children, neuroblastoma, very common site of metastasis in children is in the orbit, comes from the adrenal medulla, and in adults, metastasis comes from the breast and from the lung, could be the prostate. And this is a very important table, as we said. And then we talk about different lesions you mentioned in the table. So in adults, we are going to separate orbital pathology into pathology in adults and pathology in children. Pathology in adults, Graves' disease, thyroid ophthalmopathy, orbital cellulitis, orbital pseudotumor, the lymphoma, metastasis, mucoceles, vascular lesions, as we said before, lacrimal gland tumors, meningiomas, dermoid and epidermoid, as we said. It also can be noticed in adults. And let's talk about the thyroid orbitopathy, Graves' disease. Thyroid orbitopathy is an autoimmune disease in association with the thyroid. It could be present in thyrotoxic patients, or it can be present in new thyroid patients. And in these cases, you get gritty sensation, photophobia, you get lacrimation, discomfort, limited motility of the eye, and this is active motility. The patient cannot move the eye because it is a disease of the muscle. It affects the muscles of the orbit, and you cannot move the muscle passively, what we call the forced duction test. If you hold the muscle with your forceps, you cannot move the globe, cannot move the orbit because of the fibrosis and shortening of the muscle, and it can result in severe cases, diminution of vision. There is lid retraction. This is a very pathognomonic of thyroid ophthalmopathy. You get staring look, you get the upper sixth of the cornea is no longer covered, and there is also the lid lag of the upper lid. When you look downwards, there is no lagging of the upper lid, and it also due to involvement of the levator palpebrae superioris. You get proptosis, is the most common cause in proptosis in adults, and in severe cases you can get exposure keratitis. You can compress the optic nerve, you get optic neuropathy, and severely affection of the muscles, as we said. And the treatment is with steroids, and if it fails, you do remove the walls of the orbits to give more space for the muscle to occur, to accommodate. You can remove the roof, the lateral wall, the medial wall, and even the superior wall, the floor, to get space for the muscle. And differential diagnosis of enlarged muscle, the first of them is Graves' disease, but also pseudotumor can involve the muscle. Orbital cellulitis can inflame the muscle and increases it in size. AV malformation can impede the venous drainage of the muscle. Same for carotid cavernous fistula. Infiltration by a locally malignant tumor or hematoma in a muscle can get spontaneous or traumatic. Causes of enlarged extraocular muscle. And a very important difference, if you are in doubt about thyroid orbitopathy and pseudotumor, the thyroid ophthalmopathy affects any muscle, the medial rectus, lateral rectus, but it respects the tendon of the muscle before its insertion into the globe. But the orbital pseudotumor does not respect the tendon, so there is thickening of the whole muscle and the tendon. It's a very important difference. And we talk about the second cause of proptosis in adults, orbital pseudotumor, although it can occur in children, but it is occurring also in adults. It is one of the most common causes of unilateral proptosis. We're starting by the common, and it is a general disease of middle age and usually has an acute onset. You get a severe onset of orbital inflammation. You get painful ophthalmoplegia. When you move your eyes, very painful. You get edema of the lids, edema of the conjunctiva in 50% of the patients. The 50 others, it is a more indolent course. This is less aggressive course. You can get gradual progressive proptosis. So it can be acute or chronic. And one of the most characteristic signs is that it regresses with steroid therapy. So it is called like a therapeutic test. If you give steroids and the proptosis disappears and the redness disappears, this is most probably an orbital pseudotumor. And of course, the treatment is not surgical. Pseudotumor may involve all intraorbital structures, as we'll see. So pseudotumor is an autoimmune inflammation depending on which part of the orbit is inflamed. If it is inflaming, it's reaching the muscle, it is myositis. Reaching the nerve, it is optic neuritis. Reaching the fascia, it is fasciitis, and so on. And this is a case of acute onset of orbital pseudotumor. You get inflammation of the eye, you get redness of the conjunctiva, you get edema of the upper lid and rapid proptosis. And the second type is chronic form. You get gradual progressive proptosis. You think it's a tumor, but it is a pseudotumor. So this is a pseudotumor involving all the structures, involving the nerve, involving the muscles, involving the fascia in one eye. It is usually in one eye, and this is another pseudotumor involving the muscle, the lateral rectus muscle, and the fascia bulbi around the orbit, and edema of the upper lid. Another case of orbital pseudotumor here is involving the optic nerve and the dura and the meninges, optic neuritis, and here other sites involving the muscle. It is not usually bilateral, but it can be, but mostly it is unilateral. Orbital cellulitis is related to bacterial infection. The other one was autoimmune infection. This is a real infection. Infection of the fat and muscle around the eye, and it can occur from where does come the organism? From sinusitis. You know that the sinuses, ethmoid and frontal sinus near the orbit, come from infection in the face. You have a wound in the face, in the dangerous triangle of the face, from the tooth. One tooth infected can reach the dental caries, and trauma. And it can be cellulitis or forms an orbital abscess that has to be drained. And it can reach the brain also via the cavernous sinus. So orbital cellulitis is very dangerous, not because of vision also, but because it can extend and cause meningitis. So this is the dangerous triangle you all know in the general surgery. Any infection in this region can reach the orbit and the cavernous sinus, causing orbital cellulitis, cavernous sinus thrombosis. And this is a case of orbital cellulitis. You find there is inflammation of the upper and lower lids and inflammation of the globe. And another case, redness, hotness, inflammation, fever. And this is a case of subperiosteal abscess because of cellulitis and infection of the orbit from the ethmoid, from the right side extending. As we said, from the sinuses, infection can reach the orbit. And this is another case also from the ethmoid and the nasal cavity reaching subperiosteally, or it can involve the whole orbit. So this is orbital cellulitis and orbital abscess. Orbital tumors, one of the common tumors we're talking about the frequency, it is not uncommon in the orbit in adults, is the orbital lymphoma. It is common type of non-Hodgkin lymphoma, and it is diagnosed via orbital biopsy. Orbital biopsy in the orbit is very, very important because many of the orbital lesions are not treated surgically. They can receive radiotherapy or chemotherapy or antibiotics or steroids, as we said. So biopsy is very important, and they can be similar. Sometimes you cannot differentiate by radiology, and as you all know, as any lymphoma can be treated by radiotherapy with or without chemotherapy. They say it is more common, as we said, lymphoma in adults in the second decade of life, or third decade, and it involves mainly the inferior fornix, and it appears under the conjunctiva sometimes, giving the salmon pink appearance. But here you see that there is an orbital lymphoma involving the muscle, the lateral rectus, and it is lateral to the globe. This is the pathology. This was proved to be an orbital lymphoma. Another case of orbital lymphoma, laterally, reaching the eyelid, reaching the conjunctiva surrounding the globe. Biopsy is very important. Orbital metastasis, as we said, it can reach the globe and the orbit from the breast, from the lung, from the kidney or prostate. And the incidence of orbital metastasis is not really known. It ranges from 1 to 13% of all orbital tumors, depending on the papers published. Pathology is also confirmed by biopsy, needle or open biopsy, and the treatment, of course, is not surgical. If you want to preserve vision, you give radiotherapy, you give chemotherapy, but if the vision is lost, if the tumor is causing severe proptosis, exposure keratitis, you have to excentrate the orbit. So this is a case of orbital metastasis. As you see, you cannot differentiate between it and the lymphoma. That's why biopsy is very important. This is orbital lymphoma and orbital metastasis, sorry. And this case, orbital apex metastasis, reaching the orbital apex. From the blood, it can reach any part of the orbit. And this is another case in the roof of the orbit, destroying the roof of the orbit and the bone in the roof, and extending into the medial rectus muscle. These are all orbital metastases. Orbital meningioma is of good concern to us because these cases are mostly referred to neurosurgeons, and they are classified or subclassified into optic nerve sheath meningioma, arising from the dura around the optic nerve, either circumferential, totally surrounding the nerve, or eccentric, rising from one side of the nerve. So this is one entity of meningioma of the orbit. Subperiosteal meningioma, it is extending from the cranium, but it is not reaching the orbit itself. It is just in the subperiorbital plane. You don't open the periorbita. Third type is from aberrant meningeal tissue. You find the meningioma inside the orbit, you don't know from where. Not related to the optic nerve, not related to the periorbita, not coming from intracranial. So it is from ectopic or aberrant meningeal tissue. And there is a special entity called orbital apex meningioma. This is a very sad story. And last but not least, meningiomas with intracranial extension, either from the superior orbital fissure or on plaque. So 1, 2, 3, 4, 5 cases of orbital meningiomas. How can we study them? Just wait, see the pictures, and you will never forget it. We start by optic nerve sheath meningioma. So this is a case of optic nerve sheath meningioma, thickening of the optic nerve. How can I differentiate between it and the glioma? You see the optic nerve can be seen inside the tumor. It is not arising from the optic nerve itself. So this is an optic nerve sheath meningioma, not an optic glioma, where you cannot differentiate it from the optic nerve, and causing proptosis. And this is common in adults, while gliomas are common in children. The subperiosteal, you see here, it is extending from intracranially into the orbit, but actually it did not violate the periorbital. So this is subperiorbital meningioma. So optic nerve sheath meningioma, subperiorbital meningioma, as you see here. And here is the aberrant meningeal tissue of very good prognosis. You take it out surgically. It is not related to the optic nerve. It is not related to the periorbita. It is an ectopic meningeal tissue, and you remove it. Orbital apex is a very small meningioma that presents with rapid diminution of vision because it is a very narrow space. So any small meningioma will result in loss of vision, and as the management of optic nerve meningioma. You do observation in optic nerve meningioma until the vision is lost or severely affected, and you remove the meningioma with the optic nerve. Every attempt to remove the meningioma and leave the optic nerve healthy did not succeed. Some people give radiotherapy. The same is for orbital apex meningioma. Wait until the vision is lost and you give radiotherapy to prevent intracranial extension, or you can excise it, or you give gamma knife to reduce or to stop its growing. Orbital apex meningioma, very bad prognosis. Also, optic nerve meningioma, the treatment is to excise the nerve, bad prognosis. However, some hope for radiotherapy is popping out the last years. And the last type is with intracranial extension. So again, we see the types of meningiomas and the picture of the meningiomas. They do exist, as you see. Second entity is cavernous venous angioma. Is it common? Yes, it is common. It's not only common, but it is the commonest primary benign tumor of the orbit in adults. It is the commonest primary benign tumor of the orbit in adults. It is causing painless, mild exophthalmos, and the vision is very good, normally or mildly affecting visual acuity. Look for intracranial cavernomas also, and there is no sizable afferent for the blood supply. As you know, all the cavernomas have minimal or no afferent blood supply. If you do an angiography, it will be negative, and you can remove it via lateral orbitotomy very easily, and I'll tell you how. So, old times it was called cavernous hemangioma or cavernoma. Now they are calling it cavernous venous angioma, being of venous origin. As we said, it is the commonest benign primary tumor in adults. It is very well localized. It is very well delineated tumor, as you see, and it is not attached to anything. So actually, surgery is via lateral orbitotomy, or superior, whatever you want, or by endoscope, and you look to the proper plane until you reach the tumor. Once you reach the cavernoma or the cavernous venous angioma, you can take it in 1 minute. You will find only it is attached to a very small afferent. You coagulate it and cut it, and you take the tumor, even if the vision is 6/6. Even if the vision is excellent, you can excise and remove this tumor without much trouble. Another case of cavernoma, cavernous venous angioma of the orbit. Sorry, we talk about the orbital bony lesions, as we said, affecting the orbit, fibrous dysplasia, ossifying fibroma, osteoma, fibrocystocytoma. This was a mistake. It is actually part of the mesenchymal tumors, but it is closely related to the bone, but it is not actually a bony lesion. And we have the histiocytosis, actinophilic granuloma, and mucocele. What is fibrous dysplasia? It is an uncommon disease where the immature fibrous tissue replaces normal bone. It is an immature bone replacing mature bone. Ossifying fibroma, these are slowly growing benign neoplasms that arise usually in the mandible, usually in the second decade of life, more common in females than males, but it may also arise around the orbit. Fibrous dysplasia is diffuse, ossifying fibroma is more localized. And the osteoma, of course, can be cancellous osteoma or ivory osteoma, and it is a benign tumor arising in the skull and orbit. As we said, the fibrocytoma is one of the most common primary mesenchymal tumors. So it is not from the bone, it is from the histiocytes. And it may be benign, aggressive, or locally or malignant. So the diagnosis of fibrous histiocytoma is not enough. You should know, is it a benign fibrous histiocytoma, locally malignant or malignant? Histiocytosis X, xenophilic granuloma, is not a real tumor, rare in the orbit, but may be observed and excised. You can find mass in the orbit, in the bone surrounding the orbit, and you can biopsy it or excise it, and it doesn't recur. And last but not least, the mucocele is accumulation of mucus inside the sinus, so that we get swelling of the sinus, expansion of the sinus, compressing the globe, frontal sinus, ethmoid sinus, impeding the sinus drainage, and causing proptosis. So let's discuss the fibrous dysplasia. As we said, it is an immature bone. It is an interwoven bone. If you remember, the osteocytes in the bone are arranged in concentric lamellae around the Haversian canals. Here there is no Haversian canals. There is no concentric arrangement of the osteocytes, but they are scattered in a tissue, and they are called fibrous. The fibrous dysplasia is an immature bone. It is not concentrically arranged around Haversian canals, but there are osteocytes and osteoblasts here. This is the immature bone fibrous dysplasia. It can be focal form of fibrous dysplasia involving the lateral wall of the orbit here and part of the skull, or it can appear anywhere in the skull, replacing the skull bone by immature bone. And this is an extensive form of fibrous dysplasia, filling the nasal cavity, the maxillary sinus, the middle fossa, the clivus, and the orbit. Of course, the treatment is to correct the problem. You are not going to remove all the immature bone, but you can decompress the optic nerve and the optic canal if it is affecting vision, and you can remove any bone that is pathologically disfiguring the shape or causing proptosis. So the target is not radical excision, it is not a tumor, it is a disease of immature bone replacing mature bone. You remove the part that's causing the problem. If the patient has no disfigurement and the vision is okay, you can just observe. Fibrous dysplasia. Ossifying fibroma is more common in girls, as we said, in the second decade of life. They are common in the frontal region, and they cause a frontal tumor inside the roof of the orbit or the lateral wall and expanding the bone. And you get here proptosis. It is, the tumor is here affecting the upper lid. And this is another case. You'll see that there is bone expansion. These are the confines of the bone. The roof of the orbit, supraorbital region, is greatly expanded. And you will find this picture by the MRI, and the treatment is radical excision. So this is surgical treatment. Ossifying fibroma is for surgical excision. Osteomas, they can arise anywhere. Here is an osteoma of the ethmoid extending into the orbit. If it is producing problems with vision, problems with ocular motility, so you have to excise this osteoma from the ethmoid and from the orbit. You can do it through the superior approach. Of course, the transsphenoidal approach will be very difficult because it is extending too much laterally, and it is very solid and hard. So better, I prefer to do it from above. Another case, osteoma of the skull bone and extending into the brain, indenting the dura. Fibrous histiocytoma, as I said, it was here by mistake, but it is a mesenchymal tumor. That's why I put it with the bone. I cannot put it. Yes, it is a tumor that arises from the muscle, mainly. This is the fibrous histiocytoma, closely related to the bone, arising from outside the bone. Of course, you cannot differentiate between it and lymphoma or metastasis, but by biopsy. So, the fibrous histiocytoma is a fibrous tumor that arises from the histiocytes. What are the histiocytes? The histiocytes are part of the reticuloendothelial system in the tissues. Histio means tissues. Histiocytoma is a tumor that arises from the histiocytes, which are part of the defensive mechanism in the tissues. In blood we have macrophages, in tissues we have histiocytes. So it is a histiocytoma. And it can involve the bone. As we said, it could be malignant, could be benign, could be locally malignant. And here there is a fibrous histiocytoma that is destroying the bone. That's why I've put it with the bone. It can destroy the bone, and it is the fibrous histiocytoma. Benign, locally malignant, or malignant. Histiocytosis X, eosinophilic granuloma, is a disease of the bone, and you can have soft tissue with the bone. It is not a tumor, it is a reaction. You can leave it alone, but you have to verify the pathology before deciding to leave it alone. And here it proved to be a histiocytosis X of the bone of the lateral wall of the orbit. Of course, you cannot know it before the pathology. Here is the lateral rectus, here is the periorbita, and it is involving the bone. You see here lateral wall, and here the lateral wall is involved, and this is the bony tumor of the bone of the orbit. And it's not tumor, but it's a bony lesion of the roof of the lateral wall of the orbit, histiocytosis X, or eosinophilic granuloma. Sometimes they give steroids, sometimes observation, but first you have to verify the pathology. Mucocele, very easy. It is frontal sinus, ethmoid sinus, obstruction of the sinus drainage, accumulation of mucus inside the sinus, expanding the sinus, compressing the orbit from above, displacing the globe downwards, as you see in this case. And here you see the left frontal sinus is expanded. You see the rim of the sinus, so it is the content of the sinus that it is increasing in size, expanding, displacing the globe downwards and forwards, and this is the mucocele. Of course, the treatment is you have to drain this mucocele and evacuate it, and to avoid being secondary infected. It becomes a pyocele, which is very devastating process. So you should treat the mucocele, evacuation and drainage, and sometimes you need to remove the inner wall to relieve the compression on the surrounding structures. Intracranial causes of proptosis, we talked about, we are always in the proptosis in adults. We discussed orbital causes, we discussed the bony causes, and there are intracranial causes where the bone is free, the orbit is free, but you still have proptosis. How can we get it? If you have cavernous sinus tumor, mostly meningioma, impeding the venous drainage causing proptosis, or meningioma on plaque. There is a very thin meningioma involvement of the dura, but there is a reactionary hyperostosis and thickening of the lateral orbital wall and the anterior crinoid, causing proptosis and diminution of vision, or carotid cavernous fistula also impeding the venous drainage and causing proptosis. So these are the intracranial causes that can cause proptosis. Cavernous sinus tumor, mostly meningioma. So as you see here, it is a small meningioma in the cavernous sinus. Carotid is inside, but impeding venous drainage and causing proptosis. Treatment of primary cavernous sinus meningiomas is mainly gamma knife. Role of surgery is limited because you can affect the blood supply of the ocular nerves and you can get ophthalmoplegia. So gamma knife. Another case, intracranial involving cavernous sinus, causing proptosis, impeding the venous drainage. And this is the meningioma on plaque. As we said, it is a very thin rim of meningioma, diffused like a carpet along the dura of the temporal pole and the anterior middle fossa, and causing a hyperostotic bone involving the lateral wall of the orbit, involving the temporal region, causing temporal fullness. Actually, this is not a reaction. Hyperostosis, you find meningeal cells, you find tumor cells inside the bone. So the hyperostosis with the meningioma on plaque is due to involvement of the bone with meningeal tumor. It's not a reaction. The past used to think it's a reaction, but now we are sure it is involvement of the bone with the meningeal tumor, causing hyperostosis. Here again, usually it comes in the lateral wall and in the temporal region and in the middle fossa. So in three regions, part of it in the orbit, part of it in the temporal region, part of it in the middle fossa, and you excise the tumor and you remove as much as you can of the bone to maintain vision if it is involving the anterior clinoid, or to remove the lateral wall to improve the picture of the patient for cosmetic reasons. So the two indications for surgery in angioma en plaque, this is a very slowly growing tumor, is cosmetic improvement and saving vision. Carotid cavernous fistula, discussed before. We have four types of fistulas, A, B, C, and D. Type A is high flow type, is traumatic, related to trauma, and it is direct communication between the carotid and the cavernous sinus. It is a very high flow, severe type, and causes severe symptoms. And the other three are spontaneous, they are not traumatic, they are low flow, they are not severe, and they are related to anastomosis between the branches and the cavernous sinus, and sometimes they can close spontaneously. So the type B, if you have communication between the branches of the internal carotid and cavernous sinus. Type C, communication between the branches of the external carotid and the cavernous sinus. Type D, branches of the internal and external carotid and the cavernous sinus. Another view showing the four types together. Type A, traumatic, high flow, severe proptosis, angry eye, redness, everything, pulsations. The type B, spontaneous, branches from the internal carotid. Type C, branches from the external carotid. Type D, branches from the external and the internal carotid. This is a high flow type, traumatic, type A, carotid cavernous fistula. Look, the ophthalmic vein is completely engorged because the cavernous sinus blood is arterialized. It's very high pressure, so it does not drain the ophthalmic vein. And here is another spontaneous fistula. And here is the angiography showing the fistula, and it is enlargement of the ophthalmic vein, superior ophthalmic vein. Normally it's not apparent, but here it appears when you do the angiography because it is thickened because of the impeded venous drainage. So this is a traumatic type, this is spontaneous type. Here ophthalmic vein is very thick, here is apparent but not that thick. And of course the treatment of carotid cavernous fistula is no longer by surgery, it is by interventional neuroradiology. You put a balloon, you put a pipeline, you put whatever to close the defect, connection between the carotid and the cavernous sinus. Common orbital lesions in children. So we finished adults, not all the lesions, but as much as we can, and the most frequent lesions were mentioned. In children, we have to talk about, we can put it congenital, traumatic, inflammatory, neoplastic. Congenital, you know, the famous Crouzon's disease of craniosynostosis. If you don't know about it, you can read about it. Crouzon's disease, and you get bilateral proptosis due to small maldevelopment of the bone of the orbit, and it's causing proptosis. Or you get the meningocele or encephalocele, the syncypital type as we'll see it, or the dermoid cyst. This is congenital. Traumatic, of course, can cause proptosis. How? By orbital hematoma. Inflammatory, as we said, orbital cellulitis, abscess, pseudotumor, or mucocele. And neoplastic, we have the hemangioma, but here the capillary hemangioma is not that common to cause proptosis. Optic nerve glioma is common in children. Rhabdomyosarcoma, as we'll see, is the commonest primary malignant tumor of the orbit in children, and retinoblastoma and teratoma. and non-ophthalmic causes, granulocytic sarcoma with leukemia, and metastatic neuroblastoma, as we'll see, and lymphoma. It's not important to remember all this, but remember the first table, and you write what you found in the first table. And we are discussing special types. Optic nerve glioma is a rare tumor, but I'm mentioning it because we are neurosurgeons. We are concerned with it, and you see it so many times. Most of these tumors, or all these tumors, are benign. They are juvenile pilocytic astrocytoma, where you find Rosenthal fibers, but they are benign by pathology, but malignant by location. So it is occurring in children and young adults, age of 10, 12, 13 years, and it is occurring alone or as a part of neurofibroma. When it is a part of neurofibroma, it is more indolent course, so that you can observe them for years without increasing in size. And as we said, the policy when you have an optic nerve glioma like optic nerve meningioma, observation to benefit the utmost from the vision as much as possible. He can use his vision for years before being reduced severely or lost. So in this time you do surgery in case of loss of vision or starting intracranial extension. Of course, the two occur together, because to extend intracranially it has to pass through the orbital apex and optic canal, and the vision is lost. And if surgery is to be done, we cut the optic nerve 1 centimeter behind the globe, because it does not extend to the globe itself. And this is very important to the optic chiasm. Please, optic nerve gliomas should not be done by our colleagues of ophthalmology, because to be radical in excision and optic nerve glioma, you have to cut short at the optic chiasm. Otherwise, you can get involvement of the chiasm and extension to the other optic nerve. And the transcranial approach, because we need to go intracranially to get the intracranial part of the optic nerve. We can get the optic nerve in two pieces, part of the orbit, part intracranial, without opening the annulus of Zinn, or you can open the annulus of Zinn and get the optic nerve as one mass. But the difficulty is that you have to repair again the annulus of Zinn, otherwise you will have permanent ptosis. You can discuss it in detail in operative, but should know that you can take it one piece or two pieces. Optic nerve glioma, rare but concerning us. So this is a child, very slowly progressive, proptosis and squint, and you find a huge optic nerve glioma inside the orbit. And another case of optic nerve glioma, filling the muscle cone, and smaller optic nerve glioma, thickening of the optic nerve. Vision is preserved. If the vision is preserved, wait and see, observe until vision is lost, and then you go intracranial and you take 1 centimeter behind the globe and you cut it at the optic chiasm. Optic nerve glioma, you should cut at the optic chiasm. The tumor should be cut at the optic chiasm. Here, not to extend. Sometimes you find that there is involvement of the optic nerve together with the chiasm. In this case, it's very difficult problem, because it's involving the chiasm, what we call the optic pathway gliomas, optic nerve, optic chiasm, optic tract, or even the hypothalamus. This case is the treatment in children is chemotherapy. Sometimes they do respond to chemotherapy. They are benign tumors, but you cannot excise the chiasm, so the role of surgery is biopsy or limited excision, and then chemotherapy. Optic nerve glioma with chiasmal glioma involved. Lymphangioma, it's not common. It is a benign vascular tumor, congenital in origin, very, very, very thin-walled. This is the problem. Imagine there is a cyst inside the orbit, diffuse, irregular, with a very thin wall. This is a slowly growing tumor that takes years to become apparent. The tumor may affect the conjunctiva, the lids, and the orbit associated with extraorbital lesions. So you find some cysts in the palate or the face, and you should check also the brain. There is association with intracranial vascular anomalies. The very strange thing is that the orbit has no lymphatic drainage, but you still can get lymphangioma. And another peculiar character is that the lymphangioma increases in size when you get an upper respiratory tract infection, viral infection, as if the lymph nodes are enlarged and the lymphangioma is enlarged. And here is the picture of lymphangioma, diffuse, thin-walled, involving the lid, involving the conjunctiva, in a child, usually 7 or 8 years old. And here you see it, diffuse lesion, but you see fluid level inside it. Yes, there is intra-tumoral hemorrhage, what we call the chocolate cyst. You find dark blood in it like the ovaries. Unlike the cavernous hemangioma or the cavernous venous angioma that bleeds on the surface, cavernous lymphangioma bleed inside and cause increase in size, rapid increase in size due to bleeding. Look here, you can find fluid level, blood inside the tumor, and here blood inside the tumor. So what is the treatment? The treatment is observation as long as the vision is okay. But if it is increasing and the vision is reduced, you can aspirate from the skin of the lid or from anywhere. And this aspiration can give you a period of 6 months, 1 year, sometimes 2 years without problem. And then when it recurs, the hemorrhage, you repeatedly aspirate. Anything else we can do? Some advocated injecting sclerosing materials, but it doesn't work. What is the third option? When it is an extensive and it is recurrent for years and the vision is lost, you can do an orbital excenteration and artificial eye. So no one, please, no one can tell me that I'm going to excise a lymphangioma. You cannot excise a lymphangioma. Very, very thin wall, you will not find the wall of the lymphangioma. If the vision is preserved, observation and aspiration. The vision is lost, extensively increasing in size, orbital excenteration, artificial eye. Rhabdomyosarcoma, is it common in children? Yes, it is common in children. Actually, it is the most common primary malignant tumor of the orbit under the age of 15 years. So you see here that the age is very important. When you tell me the age of a child with proptosis, I can tell you the pathology or the differential diagnosis. So rhabdomyosarcoma is common in children under the age of 15, age of 8, 9. So the average age is 8 years, and it is more common in males than in females, unlike the ossifying fibroma. 5 to 3.5. It is mostly affecting the medial rectus muscle. Why? I don't know, but it is a common finding, rhabdomyosarcoma of the medial rectus. And if you want to preserve vision, if it is early, you give radiotherapy is the treatment of choice with or without chemotherapy. So please, when you have rhabdomyosarcoma, it is a very, very progressive tumor, rapidly progressive, to the extent that if you have a rhabdomyosarcoma in a child in a weekend and you are in doubt, you have no pathological verification, give a dose of radiation the weekend until you verify the pathology. Rhabdomyosarcoma. Treatment of choice is radiotherapy. We are not the treatment of choice because you have to do orbital excenteration. If the patient is seeing the tumor is small, it melts with radiotherapy. The tumor melts with radiotherapy and with or without chemotherapy. The role of surgery is only for biopsy or excenteration if there is exposure keratitis and loss of vision. And when treated, it is of good prognosis. When the parents ask you, and after that you said yes, if it is managed early, it is of good prognosis. Rhabdomyosarcoma. Child with rhabdomyosarcoma, undifferentiated cells, sarcoma cells, involving the medial rectus, extending to the upper lid, increasing in size day by day. Every day you find more rapidly progressing, very aggressive tumor. Look, when you see it, leave it for a few days, 2 or 3 days, you find this also arising from the medial rectus, also in a boy, causing proptosis, biopsy, and radiotherapy. Metastatic neuroblastoma is a very special entity in children. As you know, metastasis is not common in children. But if you see a child at the age of 6, 7, 8 years, and you find there is a swelling of the upper lid, and this is the commonest site of predilection here, it affects the pterion always, and it grows in different directions in the orbit, subcutaneous and intracranially. So you should suspect a metastatic neuroblastoma. You see here that the bone was intact. When you see soft tissue inside and soft tissue outside the bone, and the bone is intact, it is either malignancy or inflammation. Because the malignancy and the inflammation, they respect the dura, but they not respect the bone. We have wide pores, so it can extend from inside to outside without destroying the bone. So when you find something, it is not inflammation in a child at the region of the pterion, age 6 or 7 years, you should expect metastatic neuroblastoma. So what should you do? See, this is the site of preference of the metastatic neuroblastoma. I've seen several cases in my life, and even it can affect not only the orbit, any part of the skull, as you see, soft tissue inside, soft tissue outside, intact bone, malignancy or inflammation. If there is no signs of inflammation, it is malignancy. In these cases, what should you do? Biopsy? No, there is something you should do before the biopsy. You should do an abdominal sonar immediately, and if you find the neuroblastoma affecting the adrenal medulla, you don't even need a biopsy. If you find this lesion, so any child at this age having a mass in the pterion reaching the orbit, having a mass inside and outside the bone, you do him an abdominal sonar. If you find or a CT or an MRI abdomen, if you find this lesion, it is metastatic neuroblastoma. The treatment is not ours. Refer him to the pediatric oncologist. Retinoblastoma is a tumor of the eye. Remember, rhabdomyosarcoma is the commonest tumor of the orbit in children, but here is the commonest tumor, malignant tumor of the eye. And as the eye is one of the contents of the orbit, so ocular tumors are causing proptosis. Mostly they are children less than 5 years old. It can be disastrous, affecting both eyes, and very good sign is the white color in the pupil. You can see the retinoblastoma from the pupil, and it is of good prognosis with 99% 5-year survival if early treated. If not early treated, it can be fatal. So this is what we call white color in the pupil. White color in the pupil. Retinoblastoma. This is the picture. Look, it is inside the globe. It is inside the globe, or it is inside and outside the globe. So if you find the tumor in a child less than 5 years, and you find the white picture in the pupil, and you find that although it is extending outside the orbit, the globe, it is still inside the globe. You find part of it inside the globe or all of it inside the globe, it is a retinoblastoma, and the treatment also you refer to the oncologist. It's not our domain. Retinoblastoma. So in this case, you don't even need the biopsy because it is tumor malignant inside the eye in a child less than 5 years old. Retinoblastoma. Orbital granulocytic sarcoma, what we call the chloroma. You should know about it because we can see it. We can see it in life, and it is in children with leukemia. What they call it is a leukemic deposit. Actually, it is a localized form of leukemia of myeloid origin in the orbit, Also, the age of affection is 8 years. So rhabdomyosarcoma, 8 years. Chloroma, orbital granulocytic sarcoma, 8 years. The retinoblastoma, 5 years, and so on. From this, you know the importance of the age with the orbital tumors. So, also, it is a malignant tumor. It is what we call the leukemic deposit. Actually, it can occur before, during, or after the occurrence of systemic leukemia. So you can find that the patient can occur before, get this leukemic deposit in the orbit, and there are no systemic signs of leukemia before it arises, or during treatment, or after the occurrence of systemic leukemia. It can cause this localized form of leukemia inside the orbit, granulocytic sarcoma or chloroma, and causes rapidly progressive proptosis. See the conjunctiva and the proptosis, you cannot close the eye, exposure keratitis, and you get extensive tumor filling the orbit. Of course, this is not our domain. Refer them to the pediatric oncologist to treat the treatment of leukemia. Another case. In this case, you might be perplexed, so you have to take a biopsy. Look, it's not from the medial rectus, but can arise from anywhere. And last but not least, the syncypital encephalocele, which are the encephalocele related to the face and nose. Further subdivided according to the defect. What is the encephalocele? It is, or meningocele, it is a dural defect that allowed part of the brain to come out and part of the meninges to come out of a bony defect. So according to the defect, it can be from the nose, nasofrontal, between the nose and frontal sinus, nasoethmoidal, between the nose and ethmoid sinus, and nasoorbital, between the nose and the orbit. And management is closure of the defect. You go inside, you close the defect, excise any gliotic tissue, you repair, and you should have with you a maxillofacial surgeon to correct the associated facial anomalies, or you can do it in 2 stages. You close the defect by suturing the dura itself, or by putting fat in the defect if you cannot suture, and you ask the maxillofacial surgeon to repair the nose and the forehead and things like that. So this is syncypital encephalocele. And according to the defect, you find this defect is in the ethmoid, nasoethmoidal, and it is reaching also the frontal region, nasofrontal defect. You find the defect, you open, then you take out the gliotic brain, you close the dura. Look here, nasofrontal from the nose, the frontal region, nasofrontal encephalocele. Thank you very much for your attention. I hope we covered most of the important subjects in the orbit, and next lecture we are going to come back to our usual, and we are going to discuss other cases of applied neuroanatomy. As we said, this was a very special lecture, but I prefer to put it immediately after the orbital anatomy so that you can be totally oriented and acquainted with the orbital lesions. I hope it was of help, and we hope to meet soon. Bye.